Hello? I think this is working. Okay. Well, welcome everyone. I'm so excited to be moderating this panel today, where we're going to be bringing together some caregivers and pediatric specialists in NMOSD and MOG and talking about the experience of growing up with these diseases. So without further ado, I probably introduced myself just now before, but I'm Nell. I just turned 17, and I've had, yeah, Sumaira. Older than you thought, I know. I am a junior ambassador to the Sumaira Foundation, and I think if we could just start with introductions with everyone.
Should I start? Sure. Hi, everyone, again. I'm Dr. Maggie Kang. I'm a mom caregiver to Nell.
Nothing else to say.
I'm the non-doctor of the group. I'm Dini Rao. My daughter Ione, who was here and sitting at that table earlier, is 8 years old, second grader, living with MOGAD and another rare genetic disease called Prader-Willi syndrome.
Hi, everyone. I'm Brenda Banwell. I'm the chair of pediatrics and pediatrician-in-chief at Johns Hopkins. And I've been involved in pediatric neuroimmune diseases in terms of their diagnoses and care since 1999.
I'm Ilana Kahn. I work at Children's National, and I am a pediatric neurologist there. I run our MS and pediatric neuroimmunology clinic. We've been going strong for about 10 years now, and I've had the pleasure of taking care of some of our kids up here.
I'm Dr. Scott Choi. I'm Nell's father and the husband of Dr. Maggie Kang. I'm kind of nervous because Nell's going to ask some questions of me, but I've been practicing.
It's the time I get to grill my dad.
I've been practicing gastroenterology in this area for about 20 years, and if you have any digestive questions, I'll answer them after the panel. Thanks.
Well, thank you all. I think where I want to start is kind of the first stage of like this whole journey, which is at the diagnostic stage. And so, Dini, I wanted to ask you, can you take us back to the moment where you first knew that something was going on with Ione?
Sure, yeah. So because Ione has another rare disease, Prader-Willi syndrome, it was a little bit tricky in the beginning. Kids with Prader-Willi don't experience pain or other symptoms typically. They don't spike a fever, for instance. They never throw up, and they rarely complain of pain. And so when Ione started saying, "Mom, I have a headache, I was kind of like, what? Something must be really wrong. But of course, you take a child to the emergency room with a headache, and they're like, it's okay, she's just got a headache. And I'm like, no, you don't understand. This kid does not complain of pain. And then she started, so we went in and out of the ER 3 times, and then she eventually started crying out of pain, just with so much headaches, they couldn't figure out what was going on. And then she started to get weakness. She wasn't able to walk, and it was very clear that the ADEM, the encephalitis, was setting in. We didn't know MOGAD at the time, but we did know encephalitis. And luckily, Dr. Kahn was the doctor on call once we finally got admitted. So we'll get to that later, but that was very good fortune.
Wow, I'm sure. And I think that the complication with other diseases for sure. And I'm so glad that you were there to advocate for her, because the mom always knows the best of the kid, so.
Absolutely, and I'll tell you one other quick thing about that, is that Ione was a late diagnosis with Prader-Willi syndrome. She wasn't diagnosed until she was 5 years old, and so I'd had practice in knowing that if I don't get out there and advocate, nothing's going to happen. She's not going to get diagnosed.
Wow, yeah, for sure. And Dr. Banwell, I know that Sumaira actually mentioned this to me earlier, that you helped create the MOGAD criteria. Could you speak a little bit on that and how pediatric patients were included in that diagnostic criteria?
Well, when you're writing international diagnostic criteria as a pediatric neurologist, you get to include kids. So that was part of it. I think, I've had the privilege of serving on the diagnostic criteria for multiple sclerosis in 3 different iterations, for leading the international criteria for MOGAD. And I'm now on and I have been in the past, the NMOSD diagnostic criteria. So I've had the relatively unique experience of being able to be part of all of these really important diagnostic criteria. And of all the things I've done professionally, these are amongst my favorite activities. We work really hard. Making the MOGAD criteria, this was our COVID project. We met every Friday morning. For me, it was either 5 a.m. or 6 a.m. We had 73 meetings, all by Zoom. We had 21 people from 14 countries. My colleague in Japan, who is, he won't tell me how old he is, and I've never asked, but I'm assuming he's in his late 70s at least. He's the most senior neurologist in Japan in terms of this field. He slept in his office every single Thursday night for 73 weeks so that he wouldn't miss the call, which for him was at 2 a.m., and he didn't want to miss it, and he lived too far from the hospital to come back in the middle of the night. That's the loyalty we have when we write these criteria. And we really care that they are for our community. We don't write them for us, we write them for you. And so these criteria were born from numerous conversations with patients and families. I love meetings like this because I learn from you, and this makes us better as diagnosticians and as clinicians and frankly as people. And I think that's really, really important. And MOGAD absolutely affects children, arguably maybe even to a greater proportional extent than in adults.
Yeah, thank you for sharing. And I think it's so lucky that we now have these diagnostic criteria set and even treatments available. And so kind of moving to the next stage of things after diagnosis and treatment, from the transition from being maybe an inpatient to an outpatient. For the doctors on this panel, how do you support patients in this transition from acute treatment to disease management at home?
Happy to talk about that. So I think this does speak a little bit to everybody's journey is a little bit different, right? And to the extent in which someone is affected changes. So oftentimes we focus a lot on what's happening in the hospital, right? That's easy to talk about. You're going to get your high-dose steroids, you're going to get this and that, but what does it look like when you go home? And so the extent of everyone's disability is a little different. So oftentimes they'll have a transition, sort of what I would call like that subacute period to maybe a rehab. And I think knowing your rehab facilities around and understanding what that process is like is really important. And I think one of the things that I have learned a lot as a physician who works with rehab doctors is what that looks like. And so much growth and so much happens in that setting that it's really nice. And then transitioning back to the office, so making sure that you have a home and a place to come to. So we've worked really hard in our program to put together a multidisciplinary clinic, which when it works really well, and we're really proud of our group. So we work with a rehab team, neurologists, as well as neuropsychologists, social worker, and a research team. Not everyone's going to have that, but having that open and honest conversation with your doctor, making sure that follow-up is set up relatively soon, right, so that you can just sort of check in and see how things are going is really important. And then planning what that long-term treatment is going to be. I will say that one of the hardest parts of that transition from the hospital or after that acute illness in MOGAD is this going to happen to me again, right? So you've talked a lot about with NMOSD, we say, well, now I have this. Now I know maybe I'm going to relapse, maybe I'm not, or I'm going to start a medication. With MOGAD, we don't know that right now. And so I will say that this conversation is almost always the most difficult, because you're saying, well, doctor, tell me, is it going to happen? How do I know? And we're saying, we don't know. We're going to be here for you. We're going to watch really closely. And if something happens, you know how to get us. And you come right back, and we address it, and we start a new treatment route, right? But I think right now, that's really the most difficult, most challenging place to be, especially I would think from a patient perspective.
Yeah, definitely. And I think especially that challenge speaks even more, I guess, from a kid's perspective too, when, I mean, I'm sure like Dini and my parents can attest, like you just want your kid to be able to have that normal, like free life. And I guess I kind of wanted to ask Dini or both my parents as well, like, do you remember experiencing, like, was there a struggle, how do I phrase this? Do you experience challenges, I guess, in terms of talking to your kid and telling your kid, hey, your life is actually really different now? How do you explain this new uncertainty and this new condition that they have and how their life's going to be different?
Okay. Yeah, that's such a big question, and I think it's hard for every parent. And even if a child doesn't have rare disease, I think Nell was in 4th grade, she's going to 5th grade, like every year there's always something, friendship shifting, new teachers, something you discover that's a challenge. You don't make it onto the lacrosse team, there's something. And I feel like once you add in the piece of the rare disease, it just amplifies the challenges of all of that. So I feel like in trying to sort all of that out as Nell was transitioning to her life outside the hospital and I guess living with this rare disease, I think we were just deciding to be very open and honest with her about everything. And I know that that's not going to be appropriate for every child, but we felt like with Nell, she wanted to know, she wanted to understand, she could read. I certainly didn't want her going to Google to find that information. So we were very open with her. And I think another level is when she's at school, she's not with us. So I think we really armed her with self-advocacy skills. And that's very important, I think, for a kid to know that they can sort of ask for things that maybe other kids may not need and that that's actually okay. And I spoke a lot with her teachers. I worked with the guidance counselors at school. I mean, I was there all the time. I don't know that they always appreciated that in terms of trying to tell them all the things because nobody knew what her disease was. And honestly, it scared people. And so I had to be there to explain and to just let them know it's okay and call me. I can pick her up and that's fine. And the first time that she was sort of going back to school, she didn't go for full days, and that was actually okay. And so we just basically sort of transitioned her in the way that she needed. And sometimes that just takes like a daily assessment, and a lot of times you're just not going to know how it's going to look, and it gets messy and vulnerable, and it's scary. When I pick her up at the bus stop, I don't know what I'm going to get. Was her day horrible? Did some girl decide not to talk to her? What happened? I mean, but you just you manage, and every day gets, I think, a little bit better, but the transition between elementary and the middle to high school is always a little bumpy, but that is probably the case for everybody. So I think my best answer to that is it's different for everybody. I think for us, we were just very open with her, and that worked for us.
Dini, did you want to add something?
Yeah, I was just going to add from the cultural perspective, you know, a lot of people in my culture don't talk about illness. And what I grew up seeing was that people would whisper in the corner and say like, oh, like Aunt so-and-so, she's got cancer, or like this or that. And so I was very determined as soon as Ione had Prader-Willi syndrome, no one was going to whisper about her because I was going to say it out in the open to everybody and answer all their questions about it. And it was going to be very natural to Ione. So it's funny because when she got the MOGAD, her biggest thing was about like they have to poke her so many times to start the IVIG, and it takes forever, and she has really teeny tiny veins. And so I actually bought her like a kit that they use for nurses to learn how to insert the needle in and the IV in. And we practice at home on this little, you know, doll thing because the more she understands the science of everything, and I try to explain everything in a lot of detail, it demystifies it and gets her more comfortable with it. And same for the siblings, because I'll say that's the other experience is there is the child who's facing the rare disease, and then there's the experience of being a sibling to someone with a rare disease, which really requires a lot of hands-on emotional support, and we have a therapist for my other daughter just to support her in that.
I'm so glad you brought up the entire thing about emotional support too, because I think that sometimes that's a component of living with a rare disease that gets so lost in the everyday, oh, we have to make sure, you know, you're good on like a physical health standpoint. And I guess I'm wondering, well, for the doctors, first of all, is this something that you try and also include in terms of like holistic care and not just seeing the patient as a patient, but as a full person? And I guess what resources do you all offer for patients in terms of mental and emotional health?
So first of all, you know, I firmly believe we treat the entire human being that we are privileged to look after, and it's not separate. Our mental health and our physical health aren't two disconnected entities. They are us. So I talk about mental health with all of my patients and their families, because that experience isn't the same for each person in the family. One parent may be really grieving, the other parent is still in shock. One parent may be very expressive about their emotional needs in the moment, another is very quiet and kind of becomes a bit withdrawn. And if the child is young enough that they can't figure that out on their own, they're afraid. Children read parents, they read all of us. 2-year-olds know whether you know what you're doing or not as a doctor. But children read their parents incredibly well. They know when you're scared, they know when you're worried, they know when you're sad. And so I always encouraged families to have that conversation, which might, depending on the age of the child and their mental and emotional state, might just be, we're worried about you, we're going to make you feel better, but it makes mom and dad sad that we have to help you, that or that you need help, maybe a better phrase. Because not saying anything at all is when the kids think they are dying. They do, and then when you ask them, they will tell you that. So being upfront at whatever is appropriate for each family, it's not the same for every family, and we respect that. But being open enough to really make sure that the child in front of me knows what's going on at their developmental and emotional level. And then I kick parents out because I'm not their doctor. I'm your child's doctor, and I need to be able to talk to them. And it doesn't instantly happen. Kids don't trust you just because you have an MD or a title behind your name. They trust you because you care and because you're listening. And it can take a while before that teenager will tell me how they really feel. And that's okay. Why would they instantly open up to me because I'm their doctor? It takes time for me to be their person. And then I learn a lot. And then we absolutely have different team members, psychology, neuropsychology, social work, and us as doctors. We aren't absent from that engagement. And I think that is one of the greatest privileges of looking after anyone, is that they do trust you to tell you when they need help. And just by the way, Brian, for all of us as health educators, clinicians, members of patient advocacy, and humans in general, I am sorry you went through that morning. That should never happen. And I don't know who that person was. I hope they have become a better clinician. But the privilege of this job does not start with giving that kind of information in that manner. First of all, it was wrong entirely. But it was wrong on multiple other levels. And we work hard to educate. Every time you guys speak up as patients and families, if you ever get a chance to do it with medical students or residents, they learn so much because it reminds them of how to be a better clinician when they hear about experiences like that. So I still wish you hadn't had the experience, but thank you for sharing it.
Yeah, I think one of the things that I love about being a pediatrician in pediatrics is that beyond taking care of the whole child, we get to experience and take care of the whole family, and I think that that's really important, right? When I see students and people come in and I talk to them about being a pediatrician, I talk about sort of a more of a triangular, relationship where it's not just me and the child, it's not just me and the parent, it really is going in all of these different directions. And that changes as a child grows up, right? And as maybe earlier on, I am focusing more on talking with parents, and then, we can spend more time one-on-one or seeing, those needs are going to change as the child, as you develop and as you change. And I really love that about being a pediatrician, and I think that that's really an honor to be able to go through all of those stages and see you guys grow up and then eventually leave us, which is always sad for me. Which is terrible. That's the worst part. I just had a couple patients graduating on, but yes, I think that also this is a long-term relationship for all of us as well, right? Even if you're a MOGAD patient who has one flare, one event, and then you never go on to have another one, we're still checking in, we're still seeing, how things are going, and over time, hoping that you trust us and you open up, and we're always going to be asking those questions. And I think that everyone in this field who really has specialized in neuroimmunology and understanding these diseases does understand that it doesn't just stop on, did you have a flare today or not? And honestly, the better we get, the less flares you're having, right? And this is amazing. And I remember actually, maybe just a year or two ago, Dr. Banwell saying to us, I used to have a relapse clinic, right, for MS patients, and this just doesn't even exist anymore. And so in many ways, we're making such huge advances and we're improving things, but there's still more. And it's not just about whether or not you've had that physical flare or not, because you are a whole person and you have a long life. And when you leave us, we want you to be in a good place.
it means a lot to know that there are physicians and specialists like you who truly do want to support the patient as a full person. I'm thinking back to the time, I don't know if Dr. Haig is here in the room right now. I'm gonna call you out again, I think. But I still remember the time, like I think it was during the break when I was getting neuropsych testing done, and you asked such thoughtful questions about my actual school experience. Like, do I ever feel really rushed during class? Do I ever feel like anxious about, like going to teachers and asking for my accommodations and things like that? And I had never had a physician or anyone on my care team be just that extremely thoughtful, and just having that support, not on just like, treating my disease, but also like my daily life and making sure that I can experience my life to the fullest. I feel like that is such a beautiful thing. And I'm so lucky to have had you so much. I kind of wanted to go back on touch on this whole idea of trust that I know Dr. Banwell brought up. And I think that this is super important in terms of when you grow up, you want to have more and more independence, and you try and, break away from your parents a little bit more, maybe break some rules and things like that. But how, I guess for the parents, how do you balance managing care while giving your kids the sense of independence that they want as they're growing up?
Dad, we need to hear from you.
Well, I have a son in college, so I could probably answer this question. But for all the parents out there, I don't know what stage you are in your parenting career, but I try to model behavior rather than give lectures, and I try to meet my kids, like Nell, where they are, which means I have to be kind of like a kid, and you have to adapt and fully embrace where they are at their stage in life. So there's no one prescription for all my kids, which are only two. So I would say, and this goes to patient care too. I don't treat every patient the same. And you're talking about transitions to pediatric and adult. I see adult patients, but that starts at 16 for our group. So a lot of the 16-year-olds are so much different than the adults, so I have to meet them where they are and speak their language. And so I've become familiar with all the TikTok terms and all that stuff, because it's not just prescribing. It's not just prescribing.
Though you sometimes incorrectly use them. I'm gonna call it.
But anyway, it's not just telling my kids what to do, what to take. Same with patients. I don't just tell them, hey, this is a prescription. You have to really be their coach, right? You have to make them believe you or even like you if they're going to do something, that they really don't want to do. Who wants to inject themselves monthly with a biologic medicine to keep their Crohn's disease in check? Nell doesn't want to do that, but you have to really be someone who is their advocate. I tell Nell all the time I'm a better doctor because of her, because I see what she goes through. And before, it was not as personal when I see these patients who are on therapies. Now it's very personal, and I get it. It's a struggle. So I don't know if that really answers the question, but anyway.
Okay. I just wanted to also add from the parent perspective, and I think it was something that Dr. Banwell also alluded to. I think one of the things that I learned as a parent to Nell when she was on her NMOSD journey was that it was important for me to show up in a way for her to sort of model herself. So a lot of the times I felt very devastated just by the disease and going through my own grieving process and all of the worries about what could happen. But I found that when I took care of myself and grounded myself with the belief of hope and gratitude that we got her diagnosis and that she was transitioning to school and all of this was good, she could sort of see that in me, and that was hugely transformative, I think. And I think prior to that, my thinking was just we had to take care of Nell, and it didn't matter how I was doing. I could, not shower for days, and that's fine, but that's not okay. You should shower, you should eat, and you should show up as the sort of most complete human you possibly can for your kids so they can model themselves after you and kind of see the hope while also being aware of the realities of the condition.
Yeah, so further to the what are kids going to do in college question, if full disclosure, my daughters are 30, 27, and 24. So been there and done that, finished all of that. But more, I think, with my patients, teenagers and young adults are going to live in a society where lots of things are made available to them. And they make choices. And we hope, as parents, we've raised our children to make clever choices. We know that not everyone makes the best choice in every moment of their life. That's not human. So being able to talk to my patients as they particularly head off to college about alcohol and marijuana and sex and other things, and having them trust that we will be looking at that as an enablement. Here's your choices. This is what happens if. This is why this choice might be particularly challenging for you. This is maybe a better choice. Not don't do it, because that's rarely helpful. I actually have a grant right now that I'm finishing, totally driven by my patients, to explore whether marijuana is beneficial or harmful to children and teens with MS. By children, I mean young teens to young adults living with MS. There's a lot on Google, which we've heard a lot about today, about marijuana helping people living with multiple sclerosis. Online, you will read that it reduces fatigue, improves a sense of well-being, may reduce spasticity, which is actually potentially true. That does appear to occur. But cannabinoids, which are the actual chemicals in marijuana, stick in the brain to the very same pathways that are often badly damaged in multiple sclerosis. So is this harmful or is this helpful? And I had a lot of my patients flat out say to me, I would like to be in that study. I want to know, because I do think marijuana makes me feel better. And I want to know whether I'm harming myself or hurting myself, but I don't want to just be told don't do it, right? So to be very clear, I am not prescribing marijuana in any way, shape, or form. But my patients who use marijuana that are part of this study, and patients who do not, and we're looking at how they learn their MRI scans, disease activity, et cetera, because that's the lived experience of some of the people I look after. And so to your point, I need to listen to my patients and learn what matters to them. Research shouldn't only be what we're curious about as clinicians, and all of the clinical trials we are part of are 100% to try to make our patients better. But we also need to study what our patients ask us. And my teenagers flat out said, is marijuana good for me or bad for me? And I thought that was a very intelligent question that I needed to have an actual answer to. And so we're just finishing that study.
Wow, that's amazing. In this last bit of time, I wanted to open it up for any questions from the audience for the panel today. Go ahead. I think Jill's grabbing the mics.
Okay, so this is maybe a two-part question. Nell, you mentioned that you just turned 17, right? So have you yet transitioned into adult care? Or are you still in the pediatric area?
It's a great question. I'm still in the pediatric area, and Dr. Kahn can correct me, but I believe that I can stay through age 21. I don't know if that's true.
So at our children's hospital, we can take care of our children and young adults up until they turn 22. So at that point, I can no longer admit you to the hospital if you have, like a medical flare. And so, I think we really use that as our hard cutoff, because obviously you need to have somebody that can do that for you. A lot of people say, okay, you're an adult at 18. And in many ways you are, but in many ways your brain is also still very much developing. You're still often living with family, you're in college, you're doing all these things. And so I think most of us as pediatricians really do feel like that is still pediatric age, and that is still a time point where there are some specific things that we can help with and we can work on. And so we really take that time to focus on taking control of your medical health, right? Understanding what your illness is, being able to explain it to somebody is really important. Understanding a little bit about what it takes to make an appointment, to know when your infusions are ready or your medication needs to come in, right? All of those things. And then also helping with the college if our patients choose to go that route. We talk a lot in pediatrics about school support. We didn't actually get into that too much here, but that is a big part of what we do, right, is working with the schools to write for accommodations or special education needs. But that doesn't end in college. It's a little bit harder, it's a little bit trickier because the rules are different, but I think there's still a lot that we can do to continue with that support and make sure that our kids are successful or getting their needs met. So yes, we've got some more time, but we're definitely focusing now, right, on what does it mean to be an adult and what am I going to need to be able to do for myself.
And I think that was going to be like my follow-up was what does the transition look like for people who have NMO, SD and MOGAD when they're transitioning from pediatrics to adult care?
Yeah, so the only other thing I'll add is that, working in just a children's hospital, we don't have the same access to adult facilities, but that's where you partner with your adult programs. So, we have great relationships with Georgetown University as well. Hopkins is very close to us. So, we start talking about where's the next program for you to go, and that's part of what that transition looks like. Picking a program, making that first phone call, making that appointment is like the biggest, hardest hurdle for everybody. But yeah, we do continue to support through that, and I think it's really important.
Yeah, and I think, so I'm not finally, that's the wrong word, but I am newly at a hospital where I don't have to do that. I'm a neurologist in Johns Hopkins, and I'm a pediatrician, and I can do both. So I don't actually have to transition my patients out at 19, 20, 21 anymore. I can just keep them, which brings me great joy, which is fabulous. But for most of my career, that's not been the case. And I think the period of transition is one of the hardest in this journey. Just a year ago, I completed I would call it a study, but for me, it was just a labor of love, actually. I got to recontact about 70 or 80 of my very first pediatric MS patients that I looked after in 1999 through to 2004. That was a time when the treatments for multiple sclerosis for children were non-existent at the beginning. The literature on treatment for pediatric MS was a single report of an 8-year-old in the UK given a drug called betaferon. Here it's called betaseron. And that's where we started. And so when I was looking after these children, treatment didn't start until they'd had 3 or 4 attacks, because I wasn't in Canada at the time allowed to prescribe drugs. So it was a very different time. They had a lot. As you heard, I used to run a relapse clinic because these patients would come in so frequently, and I'd see these children and teens so often. Things got a lot better during our journey together. So I was able to recontact them. They're now between 25 and 40, so I feel 100. It was incredibly illuminating. Their stories were almost all the same. 70 to 80 one-hour phone calls, and their messages, I could have lined them all up. Number 1, mental health. As they became young adults and were moving into their own independence, they realized, and they said, this was their wording, that they had serious mental health needs that had not been met, but that they themselves had not owned and had not expressed agency over either. Like, they didn't recognize them as teenagers as symptoms until they started to emerge into adulthood and realized the help they need. Second, they realized that they didn't absorb what they had been told, that the teaching kind of went over their head at the time, not because we didn't use the right vocabulary. They were very clear that I did explain things or tried to explain things to them, but more that they just weren't ready to hear it. And they wished at 25 that someone could go back and pretend that they were their 10 or 11 or 12-year-old selves and not make any assumptions about their knowledge. Because everybody treated them like they had a decade of experience, and they did. They had lived experience, but they didn't have the medical knowledge the way that people made assumptions they had. Third, agencies like the National MS Society, Canadian MS Society had programs for newly diagnosed adults with MS, programs for teens and children with MS, but nothing for young adults who have lived through pediatric MS. And they said, they'd go to a meeting with 25-year-olds who had only been diagnosed 2 weeks ago or 3 weeks ago or a month ago, and they weren't in the same space. And they didn't have the community that they wanted. They couldn't go back to the peds community anymore, which is where they felt at home, but there was no new community for them as young adults who had gone through a pediatric onset experience. And then some of them were angry at mom and dad, which we quickly repurposed into let's talk that through. But some said, mom and dad never really told me the truth. Others said, my parents were really honest with me and I always felt informed. And the way they felt about that parent-personal dyad was dramatically different based on whether or not they've been able to have family conversations. So, and these are now 25 to 30 and plus year olds, so they had had time to reflect on all of those things. So I learned a lot from those calls. And I think the other thing was all of them had had to transition to adult care services, and they really struggled with that. When you come to see one of us, first of all, as you can probably tell, we talk a lot. We talk to our patients for an hour. I mean, it's rare that I have a patient visit that doesn't last an hour, even if it's supposed to last 30 minutes. All my former fellows will tell you that, because they've been with me and we run over, and every family knows I'm going to run over, but I'm going to run over with all of you. And they go to the adult world and they might see the actual physician for 15 minutes, the nurse practitioner for 15, and maybe somebody else for 5 or 10. They might be there for an hour, but it's not the same hour. And it's a really big transitional change. So I think transition's tough. And I think it's good to just step way back sometimes and say maybe we're not as far along in the transition journey as we thought we were.
Thank you so much for sharing that insight. And it's so helpful to hear that too, as I'm kind of embarking on this transition as well. And the recognition that you are totally listening to your patients as well. I really appreciate your thoughtfulness and your consideration to take the time and really get to know what it is that is most pressing to these patients. So thank you.
Thank you.
And yes, thank you for listening, and thank you to all the panelists. This was
Good job, Nell.
Yeah,